Good morning, everyone, and welcome to the Tyro Multidisciplinary Seminars. We have a truly international panel this morning with representation from India as well as representation from Australia. I am live in New York here, as always, or most of the time. And so I am thrilled to have the opportunity this morning to introduce Dr. Bal, who is professor and chairman of the Department of Nuclear Medicine at the All India Institute of Medical Sciences. He is a very productive clinician scientist with over 500 peer-reviewed publications, and his area of primary research interest relates to thyroid cancer and neuroendocrine tumors. Dr. Bal has co-invented the therapeutic molecule known as fibroblast activation protein inhibitor, which is utilized in radioiodine refractory thyroid cancer, neuroendocrine cancers, medullary thyroid cancers, and triple-negative breast cancer. This treatment has shown very promising results in prolonging life and improving the quality of life of those patients. Dr. Bal is a fellow of the National Academy of Medical Sciences. He is a past president of the Indian Thyroid Society and the Association of Nuclear Medicine Physicians of India. He is currently the editor-in-chief of the Indian Journal of Nuclear Medicine. I probably could speak for another 15 minutes to give you even more of a flavor of his accomplishments and what he has dedicated his career to. But I would like at this point to introduce Dr. David Pattison, who is a dual-trained nuclear medicine specialist and endocrinologist. Every time I introduce him, I have trouble wrapping my head around the fact that he's trained in both areas of medicine. He is the co-director of the Department of Nuclear Medicine and Specialized PET Services at Royal Brisbane and Women's Hospital. He is the nuclear medicine lead of the Theranostic service. He has an academic appointment at the University of Queensland, and he has special interest in nuclear medicine, in nuclear imaging and radioiodine therapy of endocrine malignancies. He established an I-124 PET service. He is the principal investigator on the I-FIRST redifferentiation trial, and he is an active member of the Tyro Medical Advisory Board. And so, as always, I'd like to invite all of our listeners to send in their questions, which I will do my best to get to by the end of the hour. And for those of us who are not nuclear medicine specialists, I think this is a particularly important session for us to better understand what is on the forefront of nuclear medicine, which has the tremendous promise of improving the lives of our thyroid cancer patients. And so with that, Dr. Bal, I'd like to turn over the program to you.
Yeah, thank you. Thank you for nice words. Nice to see you in the morning itself. It's very, very heartening, and I'm really thankful to you inviting me to talk to our experience in a country where I have personal experience of treating more than 12,500 thyroid cancer patients in my 35 years of career at All India Institute of Medical Sciences. And my interest is in DTC as well as radioiodine refractory thyroid cancer and also medullary thyroid cancer. I treat both adult thyroid cancer and pediatric. We are lucky because both adult and pediatric thyroid cancer, they come to us. So my talk will be today is on head-to-head comparison of two molecules. One is fibroblast activation protein inhibitor versus the somatostatin receptor agent, that is DOTANOC, DOTA, DOTA. All these are somatostatin receptor-based imaging. So we have compared because they are the DOTANOC is already established. So we wanted to compare our new molecule against the present one in medullary thyroid carcinoma who have been follow-up surveillance patient in MTC. I have nothing to disclose. Are you able to see my slides? Not yet.
We don't see your slides as of yet.
I think Salman has to make it share the slides. Okay, where is the shared slide? Yeah, so I have nothing to disclose about my relevant disclosures or nothing. Medullary thyroid carcinoma is a neuroendocrine tumor derived from the C cells of the thyroid, which is earlier called parafollicular cells. MTC constitute about 1 to 4% of the total thyroid malignancies. Accurate assessment of disease extent is important because overall stage is a critical prognostic parameter. Say 10-year survival rate drops from 95% for intrathyroidal tumor to 40% in distant metastasis. Hence, there is need for a novel and effective molecular imaging technique in MTC. Accurate assessment of the disease extent changes entire landscape of clinical management of the prognostic factors. Oh, I'm not able to do that. Okay. Yeah, but there is the 8th edition of the AJCC UICC, they recommend the staging, which there are group of surgeons, endocrine surgeons like Dr. Jolie Sosa and others. They have recently published in JAMA Surgery, countering the staging system proposed by the AJCC is not appropriate, but they cannot separate stage 1, stage 2, stage 4. And a lot of people in the stage 4 been grouped together, almost 30% to 35% of patient compared to 27 and 28% of patient in stage 1, 2. But when they applied the new recommendations, the stage 4 dropped to only 165. There are 3,315 patients taken from the NCDC, and then the number of patients from 1998 to 2012. Next. That's the problem with this changing. Okay, so this is the proposed staging system by this group, and they have clearly demonstrated that patient who has been stage 4, including 1B, nodal status 1B was in the stage 4, which has been now brought it down to 3, and only metastasis in stage 4. That makes a lot of difference, and that resulted in the 5-year disease specific survival rate is 100% in both stage 1 by old and new recommendations, and 97 to 97. There is no difference between stage 2, but there was significant difference in stage 4 from 40. It drops to 40% from 82%. So this is the new recommendation. Probably the next time it is going to be adopted. Next. So if you go by the ATA guideline 2015, which is quite old now, almost 10 years old, and they recommend that extensive disease and sign of symptoms of the patient present, then you need serum calcitonin level, which is to be more than 500 picogram per ml. And this, of course, is based on grade C, which is not very high. Neither FDG nor fluorodopa PET scan is recommended to detect the presence of distant metastasis, that is grade E. So what we have to do in the initial stage, workup, preoperative workup is FNAC once gives the result as medullary thyroid carcinoma. You do good neck ultrasound examinations, calcitonin and CA level, and then RET mutation. If the RET germline mutation is positive, then you go ahead and do the evaluation for FIO. It is also you have to do for PTH. If FIO is positive, first you take out the FIO and then go for the medullary carcinoma, thyroid, total thyroidectomy, plus minus neck dissection. But if its rate is negative, this sporadic, then you can check the calcitonin level. If it is less than 500, then you can do just conventional imaging, go ahead with a thyroidectomy with or without neck dissection. And if there is bulky nodes, you can go ahead with the external beam radiotherapy. But if the calcitonin level is high, then you should look for other imaging modality like CCT, MRI, and extensive evaluation using contrast triple phase to rule out triple phase CT scan to rule out liver metastasis. So this is the protocol which has been recommended by recommendation 22. And recommendation 23 says there is no need, neither FDG nor FDOPA is recommended. Next. So what is the current ATA recommendation for post-operative evaluation? If you, after surgery, when the patient comes back, you have to do the neck ultrasound 3 to 6 months later and check that measure the serum calcitonin level CA, total TSH level. And if the calcitonin level is undetected, so that means the patient is free of disease. And then 6 months to 1 year, you can further evaluate physical examination, neck ultrasound, and calcitonin level. If it is less than 150, so it is a biochemical persistent disease, but there is no evidence of structural disease. If calcitonin is more than 150, possibility of doing imaging using different modality like physical examinations, repeat imaging after 6 to 12 months, measure the serum calcitonin level, CA 3 to 6 months to find out the doubling time. These are the recommendations. If imaging is positive, then depending on the disease, you can treat them with EBRT or surgery or any local regional treatment. And if it is not possible to do operative local regional treatment, then TKIs. And that time, of course, the newer agents were not available. The TKI was available. TKI was recommended, or you can patient the patient for clinical trials. Next. So the major work from Dr. Tuttle's group from Memorial Sloan Kettering on 28 patients they evaluated with the FDG, the first imaging agent. They took retrospective study from January 2000 to October 2005. 28 patients underwent a total 38 PET scans. Calcitonin level ranged from 106 to 500,000, and median was 7,260. There were 23 true positive, 1 false positive, 14 true negative. So the scan yielding an overall sensitivity of 62%. If your calcitonin level is more than 1,000, there was 78% positive rate. But interestingly, 14 so-called false negative FDG PET scan, 8 of them underwent further evaluation and only 2 were positive. So there was no true positive finding when calcitonin level was 509. That led to the recommendation that below 500, there is no need of doing any imaging. Next. So these are this is a detection rate of FDG. Another group from Treglia, they have meta-analysis of 24 studies on 538 patients. Overall pooled detection rate of FDG PET scan was 59% in MTC per patient analysis, and pooled DR increased with increasing calcitonin level from less than 150, they got 40%, of course. But interestingly, from the Memorial, there was no detection rate. So the highest they detected 75%, which is exactly same as what they have recommended. Shorter calcitonin level, CA doubling time correlated with higher detection rates. Next. So this is one if you see the Memorial data was between 2000 to 2005 when PET-CT was not available, only PET scan was there. There you can see there is this patient as a 58-year-old female who had 860 picogram per ml calcitonin level. And when we did a FDG PET scan, we can clearly see this was that the neck ultrasound was of course negative because it was a retrosternal prevascular node, and you can see it very clearly. And we sent this patient for a thoracic surgeon and to remove it by thoracoscopy. Next. So the next agent which is recommended is fluorodopa PET-CT. Fluorodopa is a amino acid of tyrosine derived, which is upregulated in MTC, L-type amino acid transporter, and aromatic amino acid decarboxylase enzyme, and allows the F-DOPA to enter into the cells. Then F-DOPA undergoes deamination, become dopamine, and dopamine again stored in the vesicle, and it works as a neuroendocrine marker. Next. And here is the current imaging options for recurrent MTC. We can see this is the same patient who have undergone, and the left panel is the F-DOPA, and the right panel is the FDG. Sorry, DOTANOC. Is somatostatin receptor and F-DOPA. But interestingly, even if somatostatin receptor was much less intense, means screening scale 2, you will not be able to treat this patient. Then we need some future modality for treating this type of patient. Next. I'll show you later. So there was 8 studies, 146 patients with suspected recurrent MTC. Academic radiology demonstrated similar finding. When the calcitonin level is high, you can pick them up to 86%. Even if calcitonin level less than 150 picogram ml, 39% were picked up by F-DOPA. Next. Next. So again, another 5 this time another small study showing the 5 different, the 306 patients from 14 different comparison studies were included. There are FDG, then somatostatin receptor-based imaging, FDOPA, methionine, and fluorodopa. All of them was used in these techniques, and they found that on the existing tracers, FDOPA preferred for imaging recurrent MTC. Next. The major advantage of SSTR-targeted imaging is potential theranostic applications. A meta-analysis of 9 studies, 152 patients, overall pooled detection rate of somatostatin receptor PET-CT, suspected recurrent MTC was 64%, and pooled detection rate improved to 83% when the calcitonin level was 500 picogram per ml. Helps assess the feasibility of peptide receptor radionuclide therapy. Next. This is our patient, in a 61-year-old man with his thyroid FNA distribution of MTC, serum calcitonin level 30,000 close to 3,000, and Ga-DOTANOC PET-CT done for metastatic evaluation revealed tracer with large ill-defined mass in the left thyroid bed and multiple tracer and light skeletal lesion. You can see all of them are like Christmas tree lighting up. Next. So here is a patient who had a retrosternal mass, which is a known case of medullary thyroid carcinoma, both FDG, GOTANOC, recurrent tumor identified. You can see the FDG was extremely avid, whereas GOTANOC was.
This is Mark and his gene.
Next.
Thanks.
So there is, these are the unmet needs, effective theranostic application of MTC, positron emission tomography imaging in medullary thyroid cancer, time to reappraisal. This is the study showing the latter study, like ATA was 2015, then ESMO 2019, and ENM 2020. All of them advocated various indications for FDOPA, FDG,
How are you doing?
and somatostatin receptor, but ATA doesn't recommend any of this imaging for the medullary thyroid carcinoma workup. At initial diagnosis, ESMO recommends to assess the feasibility of PRRT for somatostatin receptor-based imaging. In case of short serum calcitonin and CA level doubling time, then you can do the imaging with FDG. And if the calcitonin level more than 500, you can suspicion of distant metastasis in persistent recurrent disease, and then with serum calcitonin more than 150. If serum calcitonin is more than 150, but you suspect, definitely you can ask for fluorodopa. And if it is more than 500, definitely there is distant metastasis, and these are the recommendation by ESMO. ENM, almost identical recommendations. Persistent recurrent MTC suspected more than 150 picogram, you can go for FDOPA. And in case with short duration of doubling time, you can go FDG because they are more aggressive tumor. And then for somatostatin receptor, of course, for evaluation of PRRT. Next. Next. So this is if for the people who want to really know what are the recommendations. Now the same thing has been evaluated. This is a good review article published in Endocrine Metabolism 2021, and taking all the ATA, then ESMO and NCCN guidelines and recommendations are almost what I told, identical. Next. Novel theranostic options in the horizon. Next. So this is fibroblast. What is fibroblast activation protein? The fibroblast activation proteins are secreted by the cancer-associated fibroblast caps, and these caps are the supporting cells of the tumor. Any tumor which is having a bulk of the mass, 90 to 95% of them consist of the supporting cells, and these supporting cells are epithelial to mesenchymal transformation. These cap cells produce and support the cancer cells, and they produce a protein called fibroblast activation protein. It is a transmembrane glycoprotein belonging to the dipeptidyl peptidase family. FAP is a promising pan-cancer theranostic target, negligible expression in normal adult tissue and significant overexpression in various tumor types. Cancer-associated fibroblast in the tumor stroma from a major component of the overall tumor burden. Prospective evaluation suggests FAP PET comparable or superior to FDG in differentiated thyroid thyroid cancer. There are limited literature available so far on utility of PET in MTC. Next. So to conduct a head-to-head comparison of DOTA.SA.FAPi, which is a variant of FAP, fibroblast activation protein inhibitor, we have compared against the somatostatin receptor, which is DOTANOC, for the follow-up surveillance of patient with medullary thyroid cancer. Next. So this is the molecule which we are working, and we have developed this molecule in collaboration with our chemistry friends from the University of Mainz. Next. And inclusion eligibility condition in inclusion criteria: patient with histologically proven MTC, patient who undergone both gallium-DOTANOC and SA.FAPi within a time interval of 1 month, patient who did not receive any anti-cancer treatment within 4 weeks. If they have received within 4 weeks, they are excluded. Next. So female patient who were pregnant or breastfeeding, patients with a known inflammatory condition, dual malignancies, those willing to undergo 2 PET scans were excluded. For those who are not willing to undergo 2 PET scans were also excluded from the study. Next. The mean injection activity was 5 millicurie, both for the FAPi as well as for DOTANOC. The scan was up to 60 minutes after the injection in a 228 slice PET CT scanners, and it is a diagnostic dose of CT with a parameter of 300 to 380 milliamperes, 120 kVp slice thickness of 3.75 millimeter, and a pitch of 0.6 was used. These are all technical details how we do the PET CT, and the in G-Jellyfish workstation was used to processing and analyze the data. Next. To assess the diagnostic ability of the both ready tracer, patient-based and lesion-based analysis were conducted in both primary and metastatic lesions. 2 nuclear physicians, more than 15 years of expertise in the PET scan imaging, evaluated independently without the clinical details. They were unaware of the patient's clinical history, histopathological status. Any discrepancy in the interpretation were discussed and resolved by consensus. Next. The quantitative as well as qualitative analysis was performed. Next. So the quantitative compared, we use SUV, which is SUV mean SUV and max SUV, and you can use SUV lean peak, which is the better way to express. They're all standardized uptake values. Both gallium and DOTANOC and FAPi were recorded for each side. The tumor to background ratio was calculated by dividing the SUL peak of the primary tumor and metastasis by the corresponding background and SUL peak values. Next. So true positive, we have defined PET tracer uptake in the lesion higher than the background or were found to be positive on diagnostic CT or histopathological examination. False positive lesions, PET scan, PET tracer uptake in the lesion higher than the background and were found to be negative on diagnostic CT scan. True negative, no uptake in both the tracers and on conventional imaging also negative. False negative when there is a lesion, but our imaging did not pick up. Next. So the statistical analysis were used by medical statistical software version 15, and then we did the all the statistical analysis. Then we will cook some rank tests for comparing the DOTANOC and FAPi uptakes, and then sensitivity of gallium DOTANOC and SA.FAPi examinations were calculated and compared. Next. P-value was 0.05. There's the standard things, and we next. So this is the flow chart of the patient recruitment. We had potentially identifiable patient were 50. Then 14 patients refused to undergo 2 PET CT scans. Then patient assessed 36, and then out of these 36 patients excluded again 9. The time interval more than 1 month were in 6, and HP blocks could not be reviewed at our center. So those 3 patients are also excluded. So included patients for final analysis 27. Next. So this 27 patient with MTC, mean age was 42 years, ranging from 14 to 66 years, 78% males. Median serum calcitonin level at the time of imaging was 666 picogram per ml, IQR 390 to 1150 almost. MTC sporadic in 92% and hereditary MTC in 8%. Next. So the primary treatment was offered as a total thyroidectomy and neck dissection in almost 89% patient. 3 patients presented with nodal recurrence and clearance was done. All the patient underwent a minimum of 2 lines of prior treatment. 14 patients had previously received tyrosine kinase inhibitors, 4 took mammalian mTOR inhibitors, 6 received local radiotherapy BRT, and 7 received palliative RT to the distant metastatic sites, and 4 patients received Lutathera. Next. So when we compared these two tracer on patient basis analysis, there was no difference whether there is primary tumor or the lymph node metastasis, lung metastasis, pleural thickening, liver metastasis, bone metastasis, brain metastasis. Next. So when we compare when we wanted to compare the higher degree of tracer uptake in SSTR compared to FAPi, FAPi had a much better detection rate in the lymph nodes, in the lungs, and in pleural thickening and liver, whereas there was no difference in the primary and in the bone as well as in the brain. Next. And effect of prior TKI or mTOR inhibitor treatment on PET tracer uptake, there was no difference. You can see whole table. The prior TKI mTOR inhibitor treatment did not influence FAPi or SSTR tracer uptake or imaging. Next. So this one case of 18-year-old female with the MTC, there was a big nodule you can see on the left lobe, and that this middle one is FDG. It was positive on DOTANOC, it was positive on FDG, and then patient had undergone surgery, and then after surgery the calcitonin level was still high, and then the study was done for FAPi PET. You can demonstrate there is a lot of disease in the bone as well as in the you can see the uterus in the middle of the close to the bladder. That is all the young female they will have this uterine uptake, which is a normal physiological distribution. There was bone metastasis in this patient, liver metastasis in this patient, and this has all been picked up by the FAPi. Next. And it was much better than FDG. There is another patient, 25-year-old male with MTC, disease progression on TKI, mTOR inhibitor, and even after Lutathera. So 3 lines of treatment, you can see there is still persistent disease, tons of disease picked up by both the imaging, and the FAPi shows much better. So there is again possibility of treating this patient in the future. Next. And the bone lesion also picked up. Similar studies from the literature. Next. So you can see there is a single case report from from Turkey, 38-year-old metastatic MTC for stage staging. They have 36,000, calcitonin increased to 96,000, and you can see there is a FAPi4. This is the standard which is used very widely, FAPi4. Our molecule is slightly different from the FAPi4. So we are some squaric acid FAPi, SA-FAPi, which is similar line. Next. And then this is another study from Jordan, 40-year-old metastatic MTC for restaging, and then calcitonin was 3,900, CA 134, and you can see this DOTANOC, very little uptake, whereas FAPi shows much better disease delineation in the neck as well as mediastinum and in the liver, which is FDG was not showing. DOTANOC was not showing. Then another study, this is the late break poster 592. This was recently in the American Thyroid Association 2023. 5 patients with MTC prospectively recruited for initial staging and restaging. So the lesion identified by FAPi was 293 versus FDG 63. SCB max was 4 times more. Even tumor to background was 2.5 times. Next. So these are the few studies, initial studies published. The strength and limitation of our study. It is a novel premise undertaken at a tertiary care academic hospital. Robust, consistent methodology, inter-tracer comparison analysis with the multiple readers, provides pilot data to the planned prospective diagnostic trial to confirm clinical utility of FAPi PET and potential theranostic in MTC. Limitation is single center retrospective study, small sample size. The ideal reference standard histopathology for each lesion was an impractical option, and hence diagnostic quality CT was used as an alternative or surrogate for reference standard. We did not analyze the association between the molecular signature of the tumor and the tumor uptake of FDG Theranostic. So this is what it's all about. The next. So we conclude the result of this study suggests that Ga-DOTA.SA.FAPi and gallium-DOTANOC tracers demonstrated similar detection rates in the diagnostic and in the residual tumor and locoregional lymph node metastasis, whereas FAPi exhibited a superior detection efficacy relative to the DOTANOC imaging when used to detect distant metastatic lesions. So FAPi theranostic represent a promising potential avenue for progressive MTC warrant validation in larger prospective trial. Next. So this is one of our 2009 very old patient of mine who have, you can see all 4 different imaging agent I had done in 2009. This is a 66-year-old male with a retrosternal tumor, which with a calcitonin level more than 1,000, and we did FDOPA, we did FDG, we did somatostatin receptor, and then we did MIBG, and we treated this patient. On the right panel, you can see the MIBG, and this patient survived more than 6 years after the treatment. Next. So what are the other options available systemic therapy? We have 2 approved FDA-approved drugs available. One is Vendetanib, the other one is Cabozantinib. And Vendetanib was approved at 300 milligram per day by GTA study, and Cabozantinib 140 milligram per day by exam study. And then there was allocation was 2:1, 231 in the Vendetanib group, 219 in Cabozantinib group, 100 and 111 were in the placebo. Rate mutation positive in 59% versus 46%. Median time to follow-up was 24 months in Vendetanib, whereas less than 14 months in Cabozantinib. There was median PFS was 30.5 months versus 19.3 months in the placebo group. Interestingly, when Cabozantinib used the radiological progression, they found 11.2 months versus 4 months. That means the Vendetanib study had taken even less progressive disease. That's why they got much better result. Whereas the objective response rate was 45%, and here in the 28% in Cabozantinib, and overall survival month not available in Vendetanib, whereas in Cabozantinib is 26.6 month versus 21.1 month. Though there is a lesser objective response rate, but if you compare, there is only 5.5 months advantage of Cabozantinib in the overall survival. Radiological progression at enrollment was not taken into the Vendetanib group. That is one of the major drawback of this study. Whereas in the Cabozantinib group, there was within 14 months, there was progression was enrolled. The criteria to enroll is progression within 14 months. Most common adverse events at least grade 3 was plantar from dysarthria with the Cabozantinib. There is a class effect. Vendetanib had a diarrhea, hypotension, fatigue, QTc prolongation. Next. So there are new drugs which have been selpercatinib and pralatrexatinib. These are the 2 drugs. They are phase 1-2. This is one is called Loreto trial, selpercatinib. The other one is in the Arrow trial. All they are phase 1-2 trial. Next, if you see, interestingly, even if it is phase 1-2, there is no phase 3 drug study available. There was approval by the FDA. So because these drugs are doing wonderful, because the median, the progression-free survival median is not available, but those who are, they are classified into rate mutation positive with prior TKI, rate mutation positive without TKI. So both the studies had similar design. One had 57, one had 160 milligram twice daily. The other one is 400 milligram once daily. Then the number of patients is almost similar, like 155 and is 88 and 61 and is 22. And the results are very surprising. Disease control rate is 94%, 95%, 96%, even in the pralatrexatinib is 100%. So that's why, next slide. That's why selpercatinib in MTC was approved on the first track basis, and this paper was published in phase 2 study was published in the New England Journal of Medicine way back in August 2020, and this was approved for even for children with MTC now in last month, June 2024. Next. The future direction of FAPi radioligand therapy. I presented this data in the last SNM meeting in June. This lutetium DOTA-FAPi dimer radionuclide therapy in the patient with medullary thyroid carcinoma. There are 21 MTC patients who have received 85 cycles of lutetium DOTA-FAPi, which was in our center, and we got a partial response rate of 47%. And stable disease in 47%, and the disease progression in something like 7%. So this is a new opening. Lutetium 177 DOTA-FAPi dimer therapy is well tolerated and safe, and can be a very good alternative option. For first time, a radioligand therapy is available for MTC, which is, as all the radioligand therapy are very safe, very side effects are limited, grade 3, grade 4 toxicity are very minimal, less than 5%, except bone marrow suppression, which this patient, if they have already extensive bone metastasis, that is the only limiting factor. Next. This patient ghastly looking. We first saw this patient and we thought it is a anaplastic thyroid carcinoma. We got this 56-year-old man with high-grade MTC behaving clinically like anaplastic thyroid carcinoma, presented with progressive disease after conventional therapies, FAPi radioligand therapy administered on compassionate ground. And you can see this is the picture of the patient as well as scans, and all this ghastly looking wound healed after the treatment with this. And the pain visual analog score dropped from 9 to 4, analgesic score from 4 to 2, reduction in dysphagia, and patient quality of life improved. Now he's 2 years still surviving. I hope he will go longer. Next. First in human experience. This is another medullary thyroid carcinoma patient whose daughter was initially operated for MTC way back when she was only 7 years old. Now she's a medical graduate, and her mother had a thyroid nodule, and then she presented with a lung metastasis, and some pulmonary physician thought it is did a biopsy, and they found it is thyroid malignancy. When I asked back, the same surgeon who operated neck, they had given a poorly differentiated. And when I did the FDG PET scan, there was hardly anything seen, and on DOTA-FAPi scan, we saw extensive lung lesion. So I asked the history to the mother, and she told, yes, my daughter had MTC. Then I know this is MTC. So I asked get the calcitonin and CA done in the evening. We know that this patient actually missed by the surgeon to a medullary thyroid carcinoma is meant to A. We got the genetic germline mutation study for both from mother and daughter, and they were 634 mutation positive. Then we treated with tandem 4 cycles of lutetium DOTA-FAPi. We treated, and then we provided also actinium FAPi to this patient, and now the patient is stable. Partial response has been achieved. You can see those images very beautifully. Next. So what is the future direction of FAPi? Another area which is very close to my heart is the radioiodine refractory thyroid cancer. And interestingly, we find this our work has come on the cover page of Thyroid. And this was the pilot study of 15 patients we had treated with FAPi dimer, lutetium FAPi dimer, in a pilot study in a radioiodine refractory patients, and shows very, very promising result. And now this was now 5 years we have now followed these patients, and we have treated now more than 70 patients, and we have submitted to the publication. Thank you. Next. So I'm extremely thankful to the Thyroid Foundation to give us opportunity to present our data as well as discuss our results. Thank you very much.
Okay. Thank you, Dr. Bal, for that excellent presentation. So I'll be talking now just to give a little bit of background, predominantly about the role of molecular imaging for medullary thyroid carcinoma in a more general sense, particularly for a for those members of the audience who aren't nuclear medicine specialists. These are my disclosures. So very briefly, as we know, medullary thyroid carcinoma derived from calcitonin secreting cells, with significant number of these patients having hereditary nature with the RET proto-oncogene. And it's characterized by frequent lymph node metastases and also visceral distant metastases. And so hence, as Dr. Bal's mentioned, accurate staging and restaging is critical to guide appropriate surgical management and other therapies. A brief note about global access to molecular, in particular PET imaging. There is variable access to novel PET tracers around the world, relating partly to variable cost, reimbursement models, technical capacity, regulatory environments. And so this presentation will focus solely on the potential clinical utility of PET imaging, and we'll be discussing non-FDA approved radiotracers. So I'll be talking just about the background of the different specific cellular characteristics of medullary thyroid carcinoma that can be used for localization. So this includes FDG PET, of which FDG is a glucose analog, which is a good marker of metabolism and a very good measure of prognosis, with increasing FDG uptake corresponding with worse prognosis. I'll also talk about somatostatin receptor targeted PET. We use gallium-68 dotatate at my institution, but similarly gallium-68 DOTANOC, which we've heard, is a similar somatostatin receptor imaging agent. We've also heard about 18F-DOPA, which is an L-DOPA analog. We've heard about the metabolism of that. Other mechanisms of imaging and potential therapy includes MIBG via the VMAT transporter. There's newer areas such as cholecystokinin or minigastrin receptor targeting. And as we've heard today, there's this very exciting opportunity for imaging and therapy using fibroblast activation protein inhibitor targeted modalities. So I'm going to start by focusing on these three, which are the most commonly used molecular imaging agents for medullary thyroid carcinoma. We've already seen slides on this from Dr. Bal, but one of the main set of guidelines is from the European Association of Nuclear Medicine, and their PET guidelines for imaging of MTC is that for staging, they say there's insufficient evidence to routinely recommend F-DOPA. At my institution, we do often use this and have found it useful, particularly in those patients at higher risk at diagnosis. The main role, though, it's described as in the setting of biochemical recurrence or restaging after surgery. And the key criteria that's been really defined is with a calcitonin level in excess of 150 picograms per mil. And in this setting, the first line imaging agent is F-DOPA that's recommended. The second line imaging agent is FDG. This is particularly used in the setting where if there may be either negative or lack of access to F-DOPA, which is a relatively rare resource. In Australia, it's only available in a couple of institutions. And FDG, one of the key findings, which has been alluded to already, is that it's particularly useful in those patients who've got more aggressive clinical course, or particularly with calcitonin doubling times. Certainly less than 24 months, but particularly in those patients less than 12 months are more likely to be FDG avid. And that's because of the increased metabolism associated with those more aggressive tumours. A third line recommended imaging agent is gallium-68 somatostatin receptor analog imaging, and the example I'll be using is gallium-68 dotatate. The recommendation for this is for selected cases with inconclusive anatomic imaging, be that CT or MRI, or F-DOPA or FDG results. And the key avenue where there is a main role for gallium dotatate is in the setting to assess feasibility for peptide receptor radionuclide therapy or use with lutetium dotatate or Lutathera in highly selected patients considered for this treatment. In my own personal experience, I haven't found that to have had particularly rewarding results in that setting, but it is in selected patients it can be used. This is just one trial. There haven't been that many trials directly comparing both FDG and F-DOPA versus dotatate. This is one relatively small study. I think it's from 2012 from memory, with just 18 patients. And at a per patient level, now again, it really depends on the cohort of patients that are imaged, but if that's a more aggressive cohort, if they're metastatic or otherwise. So there is variation in which tracer would be better. But in this cohort of patients, F-DOPA was superior at a per patient level for diagnostic imaging, and also at per lesion basis, it was superior again. And we've certainly found it very useful in this context. This is another relatively small cohort of patients, but this was investigating patients with a calcitonin level over 150. 12 of these patients had known metastatic disease, so at high risk, and clearly with both F-DOPA and FDG, significantly greater detection of disease in those patients with calcitonin over 150 rather than less than 150, and this informs the recommendations for imaging. In particular, in this cohort, all lesions seen on FDG were also evident on F-DOPA. And this is just one example of our own patients, 66-year-old gentleman with had restaging imaging for medullary thyroid carcinoma. F-DOPA PET at a lower level of calcitonin was negative, slightly higher again 3 years later. So this is a slow calcitonin doubling time. Again, the scan was negative. And then, 7 years later, at a higher calcitonin level, we're able to detect this disease, thyroid bed recurrence and small lymph node metastases. In particular, I've said this already, but the key role for FDG is relating to its prognostic value in imaging of MTC. This is a study of 40 patients, and it was particularly comparing FDG PET versus a calcitonin doubling time. And in particular, the cohort of patients that were FDG avid, the vast majority of these had a calcitonin doubling time less than 24 months. The patients in this cohort that were not FDG avid, so it didn't have FDG avidity, had a calcitonin doubling time over 24 months or 2 years. So really, it emphasizes that the use of FDG should really be limited to those patients with a shorter calcitonin doubling time. And the other finding, I think, from this study was that there was no correlation between F-DOPA and calcitonin doubling time. And particularly in this study, those patients who had a calcitonin doubling time less than 12 months, FDG PET performed better than F-DOPA. Just moving on to gallium FAPi PET at this point, which involves imaging of the cancer-associated fibroblasts. So a little bit of background, bit of additional background about fibroblast activation protein. So it's a type 2 transmembrane serine protease. We know that fibroblast activation protein is expressed by these cancer-associated fibroblasts. Now, this is a particular kind of fibroblast which is associated with tumor growth and is associated with poor prognosis because this promotes tumor migration, invasion, and angiogenesis. We also know that resting fibroblasts have minimal expression of fibroblast activation protein. Hence, this underpins the role of targeting of malignancy with this imaging agent. An expression of FAP is in the stroma of these tumors. So within the fibroblasts, endothelial and epithelial cells, it's overexpressed in the vast majority of epithelial malignancies. But it is important to note it can also be seen in chronic inflammatory processes. And that's part of the reason why these patients were excluded from Dr. Bal's study. And it also underpins, in fact, we've got a study at my institution, which is looking into endometriosis, so a non-malignant indication. So FAPi, which is the fibroblast activation protein inhibitor. So these FAPi molecules are inhibitor molecules of FAP, and they're internalized on ligand binding. And hence, so you get binding to the receptor internalized into the cell, and this underpins the basis of both imaging, but also that potential capacity for therapy, which involves delivery of either a beta emitter or alpha emitter, in fact, like a beta emitter such as lutetium. It delivers that within the cell, gets bound and retained there, so it can deliver that local radiation within a millimeter, which can lead to targeting and therapy. And that's really that key exciting element about FAPi. And then the reason for why that was compared to gallium todate is particularly because of the potential that this can become a theranostic agent, so using the same compound for both diagnosis and therapy. And so imaging also can be performed from 10 to 60 minutes after injection. There's no fasting or other patient preparation required. And there is a lot of excitement about FAPi PET within the nuclear medicine community. This was the Society of Nuclear Medicine and Molecular Imaging Image of the Year in 2019 from publication in Journal of Nuclear Medicine, which it just showed really this key exciting role of this imaging agent in a whole variety of malignancies. It's particularly exciting within pancreatic carcinoma, within breast cancer, colorectal cancer, ovarian cancer. There's a whole variety of malignancies. The definition of theranostics, as I've just mentioned before, prediction of response to therapy using a diagnostic test. So in summary, the concept relating to FAPi PET is that you could have this diagnostic agent such as gallium FAPi, and that can be used for a staging or diagnostic test to demonstrate the presence of that target, the distribution and the intensity of that target if it's suitable for therapy. Then instead of a imaging agent, you can apply the therapeutic agent. So this might be bound to lutetium-177, as has been mentioned. Targeted therapy can be delivered within sort of 1 millimeter of binding to cells. And then for follow-up imaging, one can use that diagnostic agent, such as the gallium-68 PET agent, to see response. If at a later time point, the disease becomes reapparent on follow-up scans, then that patient can be retreated, and that underpins this diagnostic paradigm. But one of the key elements is that if on that initial staging scan, the target isn't expressed, you can then avoid futile therapy and choose other more appropriate treatments. And so I'm just going to highlight this key slide. This is from one of the publications from Dr. Bal's group, which is, you've already heard about this, but this patient with quite extensive, intensely FDG avid disease with minimal uptake on a somatostatin receptor targeted therapy, but on the FAPi PET expressed the target adequately. You could see that on these agents and on these scans, and clearly that clinical extent of disease. This is showing retention of that treatment within the target out to 168 hours. It's one of the key challenges with FAPi PET in particular. There is concern about the retention time to deliver that radiation and adequate dosimetry, but clearly in this case there was significant retention, and then really quite remarkable clinical response and imaging response. But there was evidence of some progression at a distant site, and that's because that wouldn't have been targeted initially. But so it's very, very exciting. Just the one final, I'll finish with this slide on another similar target for potential theranostics, which is gallium chemokine, cholecystokinin receptor targeting PET. This is just published this year. It's an agent, it's a peptide receptor, and demonstrates similar concordance to F-DOPA in this individual, but it is another potential agent that can also be used for therapy. This is an Australian group from the Peter Mac down in Melbourne, and they're doing this as some of the preclinical work they're doing to optimize these traces, and they've come up with a candidate that had reduced kidney uptake and greater tumor uptake, so that better target to background ratio. And so that's just another area to watch. So as I finish now, just a few minutes to go, the key take-home messages for my presentation really is these EANM recommendations for PET imaging for MTC, the role of, from a diagnostic perspective, unfortunately, there's no therapy available linked to F-DOPA, but it's very good from a diagnostic perspective. FDG PET is a second-line imaging agent, particularly in those patients with calcitonin doubling time less than 12 months. The role of gallium dotatate, particularly if someone's considering theranostics. We know that FAPi, we've heard it's a novel, very exciting theranostic target in oncology, but also particularly for medullary thyroid cancer carcinoma, and as we've heard already from Dr. Bal's group, with RAI refractory metastatic differentiated thyroid cancer. But there are also some other exciting agents such as cholecystokinin receptor, and so that's another one to watch in this space. And I'll just finally give a plug that I'm the convener for this Theranostics course being held later this month in Brisbane. But thank you for your attention, and happy to take questions.
Great. Thank you very much. Those were two really outstanding presentations. Dr. Bal, do you have any comments in follow-up to Dr. Pattison's discussion?
Yeah, he targeted mainly the non-nuclear medicine because I wanted to cover a lot of things, because what are the exciting area. The surgeons are not agreeing with the AJCC staging, even because a ATA guideline is based on AJCC staging, and they are questioning those staging process. There is no good systemic therapy available. So in that context, so the first time we have explored a theranostic agent for medullary thyroid carcinoma, which has been explored not only in MTC, it is also radioiodine refractory thyroid cancer, in the breast cancer, in sarcomas, in pancreatic cancer. It is a pan cancer ISO, just like your pembrolizumab and nivolumab is now for all cancers, and the most of the oncology is moving towards the pan cancer detection and therapy instead of only one organ or one cancer type. So what is happening in the era is more and more diagnostic and therapy coupling together is happening. So CCK, I hope CCK will have similar line of improvement, and CCK has been there for last 30-40 years, but it has not made big impact, because then there was antibody based targeting therapy, it didn't work. Then there was blocking and binding type of therapies, chasing the antibodies, cleaning out, all they were tried in 90s and in early 2000, but did not. But I think the new agent which they are now developing, I think Dr. David will be better to comment on that.
So I have three questions for to finish up our session here. The first is, how widely available is FAPi as a diagnostic scan? Number two is, how far away are we from potentially using it as a more widespread theranostic target for medullary? And finally, my last one is for RAI refractory thyroid cancer. Where do you anticipate this to fall into our treatment options relative to redifferentiation therapy? For either Dr. Bal or Dr. Pattison.
The FAPi-4 is widely available, and it is now done almost many countries in the world, and it is very cheap. But the advantage is that FAPi-4 is one of the best imaging agent. It can be done in 10 minutes time. You can do the scan. The target to background ratio is extremely fine. But drawback, it cannot be, if your tumor doesn't hold the tracer there, you will not able to deliver the radiation. So we are looking for a FAPi. The target is same, but we want to prolong the biological retention of the tracer. Suppose you are using lutetium, which has got a lutetium-177 has got a half-life of 6.7 days. But if your your FAPi-4 within 10 minutes, so all your lutetium will go in the urine and will be wasted. So patient will not get enough radiation to the tumor. So what we have done, we have modified the molecule such that the biological retention, now Dr. Pattison showed that 168 hours the image are still, you can see the retention, 168 hours, which is about 8 days, and your lutetium, which has got 7 days. So it ideally matches. So it is the best optimum use of radionuclides, and with actinium 10 days, it's still better. So what we are trying to, for imaging, you can use FAPi-4, but for theranostic, FAPi-46 is on the market and people are trying. Then there is another 3BP is developing the 2286. There is another FAPi derivative which has got prolonged half-life. People are trying, and we have our own this GLU-FAPi, which is in the process of patenting in different countries. So it is the process. So I think there will be at least 3 FAP molecules will be available for theranostic applications.
Great. David, the final question, where do you anticipate 5 years from now that perhaps FAPi theranostic approach will be relative to redifferentiation therapy and RAI refractory?
Yeah, it's tricky. So it's a challenge. I mean, the key issue is just getting those large trials out there. So at the moment, for example, one of these FAPi agents, there are several large multi-center international trials going on. at the moment, looking at sort of breast cancer, colorectal cancer, etc. And it will take some time, I guess, to get, whether it's used on a compassionate basis is one thing, or through some of those large trials or RCTs to get it rolled out sort of more widely right around the world. I think that it takes some time to get these trials through. We've got there are a couple of large trials being done for redifferentiation therapy at the moment. We're doing one, but there've been several others, around the world. And so I guess it has to get through that stage, I think, to be able to sort of compare the specific outcomes in radioactive iodine refractory disease. But I think it certainly looks very exciting. I mean, the data that Dr. Bal has presented is very, very exciting. But it will, I guess, ultimately for widespread use, it will come down to having those trials for comparison.
Great. Terrific. Listen, thank you both very much. I thank all of our listeners and for joining us this morning, and look forward to our next session next Friday. So thank you all very much. Dr. Bal, Dr. Pattison, have a great day. Thank you.